Great job, Chris. That was really great data. And just want to, again, thank Sensible for allowing me to be here to share our experience at Mount Sinai Hospital. And you've heard this morning the use of REDS in several different care environments, and I'm going to talk about two. The first is using the vest prior to hospital discharge to make sure that it's safe to send patients home. And the other is our experience in using this in a rapid follow-up unit shortly after hospital discharge. So this is data from my colleague, Dr. Anu Lala, who published this on behalf of the Heart Failure Network, looking at 60-day event rates for patients who were discharged from hospital having been treated for decompensated heart failure. And she measured something called an orthodema score, which is basically a numeric counting of how much orthopnea is present, how much edema is present. And based upon this, you can stratify patients who are completely dry or euvolemic, a little bit congested, or a lot congested. Now, if you look at the green bar, you can see, not surprisingly, the patients who had a high orthodema score who were discharged from hospital wet had a very high event rate over the next 60 days, where almost 70% of them were either rehospitalized, had a cardiac event, or expired. And if you look at the group who were a little bit congested at the time of discharge, they also had a high event rate of 50%. But somewhat surprisingly, or maybe not surprisingly, the patients who left the hospital euvolemic, they had also a very high event rate of 50%, in spite of the fact that they had no obvious edema. Now, if you look at that group of patients who were discharged from the hospital who were completely dry without any evidence of orthodema, at least on physical examination, and look to see what happened 60 days later, you can see that about a third of them remained euvolemic on the basis of clinical grounds, but 38% had high-grade orthodema and 27% had low-grade orthodema. So there are two possibilities for this observation. The first is that maybe we're sending patients home thinking that they're dry, but they're actually wet, so they have occult congestion, or patients rapidly accumulate fluid shortly after discharge. And I think both of those are probably at play. But the opportunity for us is to identify those patients who are leaving the hospital wet, even though we think that they're dry. So we did a small feasibility pilot on our heart failure unit at Mount Sinai Hospital in Manhattan. We trained some of the nurses on our heart failure floor to be able to place the vest on patients at the time that the clinician thought that they were optimized for home discharge. In other words, when we thought that they were euvolemic. We just did this over about a 6-month period, placed the vest on. We just wanted to see what we could observe, and we also wanted to make sure that we were able to collect the data without too much effort. And what we found is that about 50% of the patients, our assessment matched up with the REDS reading. They were in the green zone with a lung fluid content between 20 and 35%. About 25% were found to be in that intermediate zone with lung fluid content between 36 and 40%. But 23%, almost 1 in 4 of our patients, where we were convinced that they were dry and ready for discharge, were actually quite wet with a REDS measurement of over 41%. Now, looking at what we could do with this information for those patients who are in the green zone, our intervention going forward would be to simply discharge them home. They're ready for discharge. For those patients who are in that yellow zone, we're going to discharge them on oral diuretics, but I think we would say that they're ready for discharge. And those patients who are in the red zone, I think this is an opportunity for us to keep them in the hospital a couple days later, treat them a little bit more intensively with some IV diuresis, repeat the REDS reading, and see whether or not we can optimize them for discharge. Now, we're going to test this in a prospective, randomized, single-blind study that's going to start probably in the next month or so, and I'll be able, hopefully in the near future, to report back to you to let you know how we did. Our other experience, which is a little bit more robust, is using the REDS system in the rapid follow-up unit. So this is a nurse practitioner-run clinic with indirect physician oversight. It has its goal of seeing everyone who's discharged from our hospital within 7 days of discharge following treatment for acutely decompensated heart failure. And when those patients are seen by our nurse practitioner, I'll just give a shout out to Jennifer, who's here in the audience. She applies the REDS vest in that rapid follow-up visit. And we think that this significantly improves our diagnostic accuracy and allows us to identify opportunities to either optimize guideline-directed therapy or to adjust diuretics. So this is the flow for a little more than a year's worth of outpatient experience. You can see in the left-hand side of the slide, we saw about 220 patients in that rapid follow-up unit. 80 had the REDS system applied. About 139 did not. And there are various reasons for this. Some of it was workflow, but others, which are probably more salient, if they had a presence of an indwelling line, if they had an ICD, if they were wearing a life vest, or if they were simply had an excessive BMI, we were not able to place the vest. I think it was very important for us to look at the patient characteristics to make sure that the group that received the ReDS vest versus those who didn't receive the ReDS vest were very similar. And you can see that except for BMI, they were identical in terms of all of the baseline clinical characteristics. In addition to that, we wanted to see how these patients were treated. And I'll remind you that these are all comers. So you'll see on there that some are receiving calcium channel blockers. And I think this was particularly true in our hypertensive heart failure preserved ejection fraction patients. But essentially, there was no difference in the way the patients were being medically managed at the time that they presented to rapid follow-up. And here are our results, very impressive results. So 30-day all-cause readmission rate of 14.1% for those patients who had a visit that was led by a very skilled heart failure nurse practitioner. But if you take that skill and you add to it the diagnostic ability to use ReDS, you can see that the readmission rate goes down to 6.5%. Now keep in mind that the national average right now is about 22%. So to be able to reduce a readmission rate down to less than 7% is really microscopic. We also wanted to see how did the use of the ReDS change how we treated these patients. This didn't happen by accident. There has to be a reason why readmissions were reduced. So we looked at our medication changes, and you can see in the ReDS group on the left, about 30% did not have any medications adjusted, but 30% had their diuretics changed. More than 30% had their guideline-directed medical therapy, ARNI, ACE inhibitor, ARB, beta blockers, MRAs adjusted. And I think that's really a point that I want to drive home, which is that knowing that patients are euvolemic or in that green or yellow zone gives us that opportunity to advance guideline-directed medical therapy. And you'll see that we did that more often with the use of the ReDS system than we did in those patients who didn't have the advantage of having the ReDS system applied. So we're very excited about our use of ReDS in a variety of care environments. We'd love to talk to you after this session or at another time. I think as time is drawing short, I'm going to step off the stage and let Dr. Feitel continue the story. Thank you very much.